Hello, this is Amjad al-Mendilawi from Baghdad, Iraq, presenting a case of coronary perforation during PCI. The case is a 51-year-old male smoker with stable angina referred for PCI to the right coronary artery. This is LIO view of the right coronary artery, shows a long critical stenosis at the middle part. As we see, the lesion is long, tight, and probably there is some calcification. This is the aerial view showing the same long lesion. So we proceeded as usual with the wiring and balloon pre-dilatation using a balloon 2.5 by 15. Angiography after balloon inflation shows some dissection as expected. So we went ahead for stenting, feeling that the dissection might progress. But it's apparent from the balloon inflation, the stent inflation, that the lesion needed more preparation before stenting. So we depended on higher pressure inflation after stenting. This is the view after the first stent, which has the longest stent available at that time. Another stent was necessary proximally and was overlapped with the distal stent. And it's obvious that post-dilatation more is required and a higher inflation pressure was needed. Following this higher pressure inflation, this is the angiography. And it's clear that there is a large perforation with a frank extravasation of dye. Alice classification classifies coronary perforation into three types. Type 1 is the presence of extraluminal crater without extravasation. Type 2 is presence of pericardial or myocardial brush without extravasation. Type 3 is the frank extravasation more than 1 millimeter. Our case is there was a frank extravasation plus myocardial and pericardial brush. When the perforation is into the chamber, it's called type 3 CS. So, what is the management in these cases? There are two major steps. First is the general approach. In that case, we have to maintain adequate blood pressure and support by giving intravenous fluid and probably blood, a balloon inflation, pericardiocentesis when required, and it's important from the early beginning of the situation to ask for help from the surgeon. The second step is specific step and depend on the type of the perforation when the extravasation persists. So if it's a large vessel perforation or a small or distal branch vessel perforation. In case of large vessel perforation, the specific step will include a prolonged balloon inflation or using a covered stent. And in rare cases, when the procedure is done during PCI, a dissection and re-entry technique could seal the perforation. In the presence of distal or branch perforation, embolization can be used with various material, or when there is a branch perforation, you can use a cover stent to seal the branch and close it. In case of failure or unstable patient, you have to prepare for surgery. So we did some balloon inflation for this patient, but the patient had severe chest pain and started to become hypotensive. So we prepared ourselves for a covered stent. Currently, there are two types of covered stents. The first is the well-known graft master stent, which is a PTFE material sandwiched between two layers of stent. It has a higher crossing profile and need at least a 6 French guiding catheter. The other one is the PK Papyrus stent, which is a polyurethane stent material covering a single stent. That's why its crossing profile is lower. So the first stent was delivered and inflated in a place the patient required another stent, a little bit more distal with overlap to the proximal stent and inflated to a higher pressure again, and this was successful in sealing the perforation completely. In conclusion, perforation can occur after stenting with higher pressure inflation. Keep calm and manage according to the protocol. Stent graft can be useful in large vessel perforation and should be available in every cath lab that perform intervention. Our patient's symptoms resolved, and there was a mild pericardial effusion without a pressure effect. He was discharged next day. And thank you.